Thank you, sir.
For our next session, we would like to invite moderators Dr. Puneet Mehrotra, Dr. Nikhil Mahajan, Dr. Sachin Chakravarti, Dr. Rahul Kishore, and Dr. Ashish Kumar Jha on the stage. And chairpersons Dr. Debbrata Banerjee, Dr. Mehrajuddin Khan, Dr. Y.C. Porwal, Dr. Rajneesh Verma, and Dr. Ritesh Shrestha to chair the session. The first speaker, Dr. Munish Sachdeva.
Good evening, Chairperson, and happy Teachers' Day to all my teachers as well as my colleagues. The today topic allotted to me is anticoagulants in portal vein thrombosis in cirrhosis. As all of us know, then in clinical practice as a gastroenterologist, what we commonly see portal vein thrombosis, mainly in our setup we see more frequently with inflammatory disease in and around the portal vein. However, the common cause in hepatology is the cirrhosis is the most common cause, which may or may not be associated with hepatocellular carcinoma or the hypercoagulable state. And this has been documented in number of studies that about 1% of patients have portal vein thrombosis at the time when they are being diagnosed with cirrhosis, and this prevalence increases further by around 5 to 7% in the natural course of disease, and by the time they decompensate and they are being listed for liver transplant, the prevalence has been seen up to 10%. So this portal vein thrombosis can be acute or chronic, or this may be related to tumor. The most important part in diagnosis, and most of us we see in clinical practice, is good number of patients nowadays are coming with increasing pandemic of obesity and diabetes, and they are being diagnosed incidentally as cirrhotic, and about 1 to 5% of these patients, they have portal vein thrombosis. So first and foremost in diagnosis confirmation as well as assessment of the disease is getting their imaging with CT angiography, not only to confirm the portal vein thrombosis, what extent of portal vein thrombosis is being seen. There are a number of classifications which has been seen, but the most accepted is the ASLD classification, where we define in thrombus in terms of location, whether this is intrahepatic or extrahepatic or combined, the length of clot, which may be intrahepatic as well as extrahepatic, and then lumen obstruction, whether this is minimal or less than 50%, or mild, which is being described as more than 50%, but not completely occlusive, and the third is the completely occlusive disease. Similarly, ASLD has defined in terms of response to treatment, whether there is progressive, stable, or a regressive clot. So portal vein thrombosis, what is the importance of portal vein thrombosis in cirrhosis? Basically, portal vein thrombosis is being associated with high risk of variceal bleed in this group of patients, high risk of failure of endoscopic control of bleeding as well as rebleed, and this has been associated with higher mortality rate at 6 weeks. An extension of portal vein thrombosis into SMV has been seen to leading to intestinal infarction and associated mortality. Portal vein thrombosis is not only associated with all these above, but also there is increase in 30-day mortality pre-OLT as well as high mortality in those who have been subjected to transplant as well, in comparison those who did not had portal vein thrombosis. So I will be taking this as I said, these patients have high risk of bleed. The time to eradicate varices has also been seen longer in those who have got portal vein thrombosis vis-a-vis those who did not have portal vein thrombosis. Another study which has shown the higher the grade of portal vein thrombosis, means the more occlusive disease, these patients have lower survival and the higher mortality pre-OLT as well as post-OLT. Similarly, the risk of decompensations in the form of ascites is being seen far more high in those who have got portal vein thrombosis with cirrhosis vis-a-vis without portal vein thrombosis. Another study which has shown that As I said, pre-OLT as well as post-OLT, these patients have higher mortality and lower survival rate. Another study which has shown that overall mortality is also increased in those who have got portal vein thrombosis. So what comes in our mind is how to prevent, and is use of different anticoagulants is safe, especially with the background of especially with the background of cirrhosis, as most of us are scared of using different forms of anticoagulants in the background of high risk of bleed, whether variceal or a non-variceal. And most of us feel that with background of thrombocytopenia, with background of elevated INR, we really scared. But at the same time, number of studies have shown that cirrhotic patients have either normal or elevated thrombin generation capacity and near normal white blood cell count formation. And this has been well studied in different other studies, that these cirrhotics, they also have elevated levels of platelet adhesive proteins like warm blood factors. They have decreased level of natural anticoagulants. So the background of using anticoagulants in this group of patients is they have almost normal or near normal coagulation profile, rather than we should be scared of bleeding in this group of patients. So with this background, those who are cirrhotics, those who have developed portal vein thrombosis, does recanalization of portal vein really helps this group of patients in terms of survival, in terms of liver function test, in terms of post-OLT survival, or does it really increases the variceal bleed? So I'll giving the answer of each one by the different meta-analysis. This meta-analysis by Quicks et al. Has shown that the portal vein canalization post anticoagulants was seen in up to 90% of the patient, with pooled rate of approximately 70%, and the complete portal vein recanalization was achieved in up to 42%. Similarly, even the use of anticoagulants have been shown that the portal vein thrombosis progression was significantly reduced when these patients were put on anticoagulants. Similarly, another part of liver's function, whether we talk of in terms of transaminasemia or ascites and albumin, these functions also improve significantly those who are managed with anticoagulants. So this, I said, complete recanalization was seen in up to 90%, while progression of portal vein has also been proven by Lafado studies. Another study which most of us are scared is that variceal bleed. So this study by Lafado has all shown that variceal bleed is less when these patients were managed on anticoagulants. So good number of studies with definite meta-analysis favors that we should use anticoagulants in this group of patients. So coming to the consensus, Bavino 7 consensus are also recommended that all these patients of cirrhosis with portal vein thrombosis or suspected or patient who are going to have presumptive liver transplant, they should not only be screened every 3 to 6 monthly, and if they have got progressive disease or their extension into a superior mesenteric vein, or they have got prothrombotic state, they should be treated aggressively with anticoagulants. Similarly, ASLD guidelines have also shown that these patients should be managed. However, the treatment varies depending on the symptoms, whether they have got progressive disease or they have got partially occlusive disease, and whether they are liver transplant candidate or not. So in nutshell, I should say that if patient is asymptomatic or symptomatic, patient has got recent or chronic disease, patient has got a partial clot formation or a complete, or are they really liver transplant candidate? The observation or no treatment is indicated in those cirrhotics where they are asymptomatic, or they have chronic or minimal obstruction, and they don't have known progression on imaging after 3 to 6 months, and they are not liver transplant candidate because of any reason, whether active drinking or uncontrolled sepsis. And we should be aggressive in those group of patients where we find that thrombosis is recent, it is symptomatic, it is partial but progressive on serial imaging, and these are liver transplant candidate. Then various anticoagulants like low molecular weight heparin, warfarin, dabigatran, apixaban have been used. Various guidelines have used these patients in different forms of liver disease. The DOACs are used in child A without any dose adjustment, while dabigatran, apixaban and oxaban can be used in early child B disease, but in all child C status, all DOACs should be avoided. So anticoagulation is the first modality of choice. Those who have got progressive disease, they have got impending intestinal necrosis, they can be well managed on thrombolysis. However, their data is still scarce. Other option is TIPS. So this is the schematic representation that those who have got recent thrombosis and they are candidate for liver transplant or occlusive disease or evident of progression of disease, they should be aggressively managed with long-term anticoagulation, and where if anticoagulation is ineffective, we should subject them to TIPS. So another group of patients where we manage with varicose bleed or refractory ascites, we should try to control, and once this disease activity is controlled, and if they have got aggressive disease, progressive disease, occlusive disease, we should manage in the same fashion. So in concluding my presentation, portal vein thrombosis is an important milestone in progression of liver disease. Portal vein thrombosis increases the risk of different complications, morbidity as well as mortality. Risk stratification and individualization of management of portal vein thrombosis in cirrhosis is important, but be aggressive in those patients who have got recent symptomatic, partial but progressive disease or potential liver transplant candidate. Thank you.
Nice picture. One question is, if we have to start anticoagulation, so should we start immediately after high risk varices, banding of high risk varices, or should we wait to heal the post-tibial ulcer?
Basically, ideally there is no timeline has been defined, but most of the time after 2 to 3 weeks we can go ahead with anticoagulation. We should not be scared of bleeding from post-tibial ulcers.
And one, so to rule out the myeloproliferative disorder in non-malignant PVT, should we search for every patient for myeloproliferative disorder, or also selected patient?
SS, ASSLD or Bavino does not implicate that we should investigate all these group of patients, but those who have got evidence of DVT or other thrombotic states documented in or seen in earlier course of the disease, they should definitely be investigated for, because all these investigations are quite costly in our setup, and the recommendation says that those who have got evidence of prothrombotic state in the past, they should be definitely investigated, or based on their investigation profile, if they've got high platelet count or suspicion of myeloproliferative disorder, so that should be individualized rather than a rule of thumb for everyone.
Thank you.
Thank you, sir. We would like to invite on stage our next speaker, Dr. Manisha Dwivedi.
Good evening, everybody. I'll be talking to you about two common clinical symptoms with which a cirrhotic patient present to us. This impacts the quality of life of the patient, but it is rarely discussed in meetings and conferences. Muscle cramps are a significant yet frequently overlooked clinical issue in patients with cirrhosis. What is a cramp? It's a sudden, involuntary, painful contraction of the skeletal muscle, which typically occurs at rest or during sleep and lasts from a few seconds to a few minutes. The prevalence range is wide, from 22 to 88% of cirrhotics, varying based on the diagnostic criteria and the study design. In surveys of cirrhosis, cramps are the second most distressing symptom after fatigue. It is an independent determinant of physical and mental health-related quality of life score. It affects the domains like sleep quality, daily activity, emotional well-being, fatigue. Most affected are the calf muscles, followed by the foot, and then the thigh muscles. Looking at the pathophysiology, it is multifactorial and not fully understood. There are three main pathways which are considered. Number one is the nerve dysfunction. The nerves are hyperexcitable, and there is oxidative injury to the motor neurons. The second is the energy metabolism, which is affected. There is reduced ATP, and there is a taurine deficiency. The third is a circulatory or volume change that occurs in cirrhotics, especially when they have ascites, a low MAP, and a high renin activity. All these contribute to motor nerve hyperexcitability, inappropriate firing, and cramps. If you see the histology of these nerves, they have an axonal loss. They are thinly myelinated fibers, and on doing a EMG, there is a spontaneous repetitive discharge of fasciculations. There is chronic depolarization of the axonal membranes, leading to hyperexcitability. There is oxidative stress, which leads to membrane instability. This explains the partial response to agents which stabilize the neuronal excitability like quinine, baclofen, and orphanadrin. Taurine is the most abundant muscle amino acid in the muscles, and this is decreased in cirrhotics with cramps. This stabilizes the sarcolemma and regulates the ion channels, and its deficiency leads to hyperexcitability. The ATP deficiency leads to skeletal muscle hyperexcitability, and if you do a biopsy, you will find a decreased ATP. There is energy failure and impaired actin-myosin relaxation, which also leads to sustained contractions. This shows you that in cirrhotics, if you see the hemodynamics, there is an initial systemic vasodilatation, there is a decrease in effective circulating volume. This predicts cramps. Ascites is also something which favors the cramps. As we said, there is low mean arterial pressure and a high plasma renin activity, leads to electrolyte abnormalities. But one thing is notable, that these electrolyte abnormalities, they are not consistently associated with cramps. Once there is a plasma volume contraction, it reduces the perfusion to nerves and muscles. This shows you the MAP and the PRA levels in patients who have compensated cirrhosis with cramps and without cramps, and then decompensated cirrhotics again with and without cramps, and you find that if the plasma renin activity is increased, it favors the onset of cramps, and so is a decreased MAP. This shows you the same thing in a diagrammatic representation, where you see that the nerves, in the nerves you have demyelination, axonal loss, and oxidative stress. Changes in plasma volume are there in ascites, and a low MAP is there. There is a high plasma renin activity, decreased ATP concentrations, and low taurine concentrations. How do you make a diagnosis? It's symptom based. There's no specific biomarker. The history is the key. You have to ask the patients, do you experience painful spasms at rest or during sleep? You can use a visual analog scale for a severity from 0 to 10, and then you exclude secondary causes like neuropathy, restless leg syndrome, medications like overuse of these medications like diuretics, beta blockers, and calcium channel blockers. Non-pharmacological management consists of stretching and exercise, especially nocturnal calf stretches, massage warm baths, hydration, and an adjustment of diuretics to avoid over-diuresis. There's an ongoing RELAX trial which is trying to see whether nocturnal stretching versus medication has a preventive role in the cramps. Then, seeing the pharmacological options, you have quinidine, There's a randomized controlled trial which showed reduced cramps. That this was in 1991. However, this has side effects like diarrhea and hematologic toxicity, which limited its use. Vitamin E, early small studies showed a positive response. However, a later RCT had a contradictory effect and even showed some worsening of the cramps. Albumin infusions have been used to expand the plasma volume, and in small crossover trial, they showed some improvement. However, it is limited by cost, an IV route, and a risk of overload. Recent pharmacological options are taurine, L-carnitine, branch-chain amino acids, baclofen, orphenadrine, methocarbamol, and pregabalin. This shows the various studies where these pharmacological agents have been used, and usually they are small single-arm studies with small number of cases. However, there was a randomized controlled trial of taurine which showed benefit. It was 500 milligrams BD in the first 2 weeks, followed by 1000 milligram BD in the third and the fourth week. And this showed a reduction in duration, frequency, and intensity of cramps in the taurine group. Other studies were with L-carnitine, branch-chain amino acids, vitamin E, and zinc. Baclofen also was found to be very effective, and there was a randomized controlled trial with baclofen 30 milligrams per day for 3 months, which showed a significant benefit. Coming to fatigue, this is the most common and disabling symptom in cirrhotics, reported between 50 to 85% of patients. It impacts the physical activity, mood, social function, and survival. However, it is not directly correlated with liver dysfunction or fibrosis. It's considered to be an extrahepatic manifestation of CLD. In the general population, it's 5%. However, in cirrhotics, it's between 50 to 85%. And various chronic liver disease have a various rates of fatigue. In this, HCV is supposed to have the highest with 90%. Fatigue is divided into 2 types, a peripheral and a central fatigue. Peripheral is due to muscle dysfunction, sarcopenia, reduced ATP production, which leads to a reduced exercise capability. And a central fatigue is because of reduced motivation, impaired attention, mental tiredness related to altered neurotransmission by dopamine and serotonin. And both types overlap in cirrhosis. Clinically, they present with persistent tiredness, non-restorative sleep, impaired concentration, may coexist with depression and anxiety. And the distinguishing feature is that fatigue often persists despite adequate rest. This is a strong predictor of impaired quality of life of the patient. The pathophysiology is multifactorial. The cytokine hypothesis states there is an increased production of interleukin 1 beta, interleukin 6 and TNF alpha, which gives rise to central fatigue. However, the neurotransmitter imbalance is there, dopamine and serotonin. Autonomic dysfunction is also there. Sarcopenia and mitochondrial dysfunction also reported. Dopamine levels are decreased, which leads to impaired motivation and apathy. Serotonin imbalance is linked to anxiety and sleep disturbances, and there is a dysregulation of the CRH-HPA axis. There are various assessment tools. Management strategies are non-pharmacological, like regular aerobic exercise, CBT, sleep hygiene. Pharmacological includes modafinil, SSRIs, and ondansetron. The take-home messages, ladies and gentlemen: cramps are common, seen in 80% of cirrhotics with disabling, it's a disabling symptom. Multifactorial, nerve, metabolic, circulatory features are involved. The assessment is by VAS scores. Treatment, you consider the reversible causes, then pharmacological treatment. However, there's a need for large multi-center RCT. Then for fatigue, it's a common disabling symptom, has central and peripheral mechanisms mediated via neuroinflammation, neurotransmitters, strong predictor of impaired quality of life of the patient, has no specific treatment, management is supportive and multidisciplinary. Future research is needed for targeted therapies, example microbiome and cytokine modulation. Thank you.
Thank you, ma'am, for a wonderful elucidation of these common symptoms. Can we have one question from the audience?
What is your take on magnesium in cramps? Giving magnesium split?
At least literature hasn't mentioned that.
Because we commonly found magnesium deficiency in patients, and I think many of the gastroenterologists and hepatologists prescribe magnesium also.
That might be a clinical observation, but at least the literature is silent on that.
Sir Anand, any comment from your side?
Okay.
The next talk will be given by speaker Dr. Varun Gupta.
A very good evening. It's late in the evening and I will try to not take any extra time for my talk. The topic is actually everyone sitting here. It's a very important topic for all the hepatologists, physicians, general practitioners. We all use hepatoprotective agents in our practice. There will be no single doctor sitting in this chamber who can deny that they have not used hepatoprotective agents. But there is hardly any evidence, and when we make a slides out of it, or when we ask someone to make a PPT out of it or explain things, the data and the evidence is so much lacking that we question ourselves that why there is no answers yet given to the society by all the senior mentors, people, presidents of MASLD, everyone, how should we go ahead with these hepatoprotectives in our daily practices. It's not there. So what do you expect from my talk? So you will like me to tell you about what are the hepatoprotective drugs which can protect the liver. So you can add more in your prescriptions. It prevents or treat or avoid recurrence in liver disease. How do you act? Should we give them to prevention, to treat or avoid recurrences? So if you are using a hepatoprotective, for how long can you use them? At what doses you want to use them? Any specific liver disease for a particular hepatoprotective, you might looking for an answer that if you have a MASLD or your patient has an hepatitis C or ALD, which particular hepatoprotective will be most beneficial in that patient, any side effects, or whether it is cost effective or not. But I am sorry, there are hurdles. There is dearth of literature, lot of dearth of literature. Still most of the agents are under research, or many which use have never undergone proper research. Standard of care is not established. Most of the trials are small and they are not RCTs, there are case control studies. The efficacy is doubtful and few of them have side effects. But we need to understand how our liver gets injured. It gets injured by oxidative stress, mitochondrial dysfunction, ER stress, immune-mediated cholestatic injury, and stellate cell activation. So we need to have some hepatoprotectives which can reduce these activation to certain extent. Hepatoprotectives in the form of herbal drugs were used in 2100 BC, and there is literature of these drugs in till 600 BC back. But I will discuss the most commonly used hepatoprotectives. So to name them, it's SEMI, NAC. NAC has some good literature. I will show you. Everyone's favorite UDCA without literature. Silymarin, metadoxin, vitamin A, again, many people favorite. And then there are newcomers, glutathione and curcumin, which are gaining importance in daily practices. So how does these hepatoprotectives act? They are mainly, some are antioxidants like SAMe and glutathione, some are membrane stabilizing agents like silymarin, some are anti-inflammatory and immune modulator like UDCA, some have anti-fibrotic action, some are mitochondrial supportive like CoQ10, like coenzyme Q10. Again, the market has flooded with CoQ10. People are using it, again, SAMe. And some are bile acid modulation like UDCA and obeticholic acid. To start with, the NAC, which has some proven evidence, it is a derivative of L-cysteine. The best part of NAC is when you have an acetaminophen poisoning, it converts itself, the acetaminophen converts itself into N-acetyl P-benzoquinolamine, which is toxic, that is NAPQI. But when you give IV NAC, immediately it converts into glutathione. So again, glutathione has a good role. It converts into glutathione and bind with NAPQI to form cysteine and mercapturic acid, which is non-toxic, and the patient immediately improves significantly. Although this paracetamol poisoning is not much seen in our part of the world. NAC prevents hepatic injury, improves hemodynamics, and may have free radical scavenging role. So this little literature on NAC, it has, if you give NAC in elderly patients, this study tells that if you give NAC in elderly patients, when you start ATT in an oral form, it prevents ATT-induced hepatotoxicity in this group of patients. This was a small RCT of 100 patients. A review on preventing acetaminophen-induced liver injury, this is well known. This is acceptable by everyone around the world that yes, if there is a paracetamol poisoning or liver injury, NAC in a dose of 100 to 150 milligram per kg body weight IV will help. But again, this is a meta-analysis and systemic review. When it comes to non-paracetamol poisoning, ALF, the study concludes, this is a meta-analysis, that NAC significantly improves overall survival, post-transplant survival, and transplant-free survival. So this is one literature which concludes that yes, NAC can even be beneficial for non-acetaminophen poisoning. There is some data that if you give NAC along with steroids in alcoholic hepatitis, there is a slightly better outcome than steroids alone in alcoholic hepatitis. This is a study where they have treated HIV patients with ATT, and again, if you give NAC preemptively to these patients, or if they have developed hepatitis, the ALT and the time to discharge from hospital improve significantly. And another study where if you start ATT on any patient and give NAC as a dose of 1200 milligram per day for 2 months, the probability of ATT-induced hepatitis becomes negligible. But when we talk about guidelines, which we follow, the EASL last talk about NAC in 2019, and the last statement they made was the efficacy of NAC to reduce the severity of liver injury from drugs other than paracetamol may not be substantiated. So they don't say that you use, and there is no statement made by anyone else, not by NASL or anything, but what should be the stand of treatment in 2025. So we are in a loop. When we talk, so coming to ursodeoxycholic acid, everyone's favorite, leave alone hepatologist. Some people have a concept that if it is hepatology, an orthopedician made a statement to me that in hepatology you just have to give UDCA, that's it. This is the concept of hepatology to other people, doctors. So this slide I borrowed yesterday from a multinational pharma group, how the sales of UDCA have risen in crores. So it was 680 crores, a very prominent, this is a patent one, I will not take the name, they have asked not to take, 680 crores in 2021, and UDCA already is 1323 crores in 2025, we are in August. And this is just one pharma group. So there may be, UDCA must be available by at least 40 to 50 pharma groups. And still, people are sitting in front, all the senior people, still there is not a single guideline or any guidance anywhere in the literature, how should we use UDCA in an Indian population or anywhere. No one has spoken about it, and the volume enormous which we are writing is endless. When we talk about, when we talk about the literature, so in the non-cholestatic liver disease, So it is well proven that UDCA has a significant role in cholestatic liver disease, but when it comes to non-cholestatic liver disease, so there is no large randomized control trial, although these small trials, case control studies show some normalization of liver enzymes over a period of time. I will skip, I'm running late. So UDCA in ALD was spoken in 1991 that it has some roles. There's gray area whether a patient had colic hepatitis should we add UDCA or not. Again, there was a survey how many physicians use UDCA in India. Almost more than 60% of the patients use in ALD. And out of that, these physicians, they found that if alone UDCA was given in ALD, they did not give any other treatment, 40 to 50, 30% of the patient will be beneficial. Again, EASL only spoke about UDCA in 2019, that the recommendation, the efficacy of UDCA to reduce the severity of liver injury, it may not be substantiated grade D. So then, if you talk about recommendation, there is no recommendation to use UDCA anywhere in the literature, but the business is 1323 crores just by the one pharma company till 2025 in August. This was the latest article in 2024 by UDCA where they learned UDCA in Delhi, and again they reviewed 30 publications, out of which 24 were case reports. Only 6 studies were there which were case control study, no RCT was there, and they concluded that it is a safe and versatile agent with promising signals, urgent need for multi-centering RCT to confirm efficacy and define dosing. Again, in 2024, same message comes in every study, urgent need for RCT, but no one is doing RCT on UDCA anywhere in the world. And but one thing is for sure, which is good, because that it is safe. It will not cause any harm, it is safe. So I'm not saying don't use it. So again, the same thing that it has no efficacy in MASLD. We cannot recommend it for MASLD today. We have so many good drugs and should be used in a dose of 13 to 15 milligram per kg. Another thing which will now come up very fast is NOR-UDCA. Again, if the topic is repeated next year, you will have another hepatoprotective agent in the kitty, but without any evidence. And this drug is there for PSC or PBC again, but again, it will be started using in, companies will start promoting it for MASLD, ALD, everything. SAMI, I will just need 2 minutes, it's important style. So SAMI, we all know it has transmethylation and transfloration pathways. SAMI, what it does, just a keynote method, SAMI increases hepatic glutathione levels. So again, NAC also forms glutathione, SAMI also forms glutathione. So SAMI increases hepatic glutathione levels, which is quite protective. And again, this is from EASL. Only few studies show some benefit in liver enzymes and pruritus given for different reasons. And this systemic review with RCT, 705 patients showed no benefit from RCT. With SAMI. So again, to summarize with SAMI, there is, we need more research and we cannot give it, approve it for any other indication. Just, there is no data to use it in any CLD or MASLD or any for long term. Silymarin is another promising agent. It is grown in Europe, Canada, America, India, also known as milk thistle. So in Western world, they sell it as milk thistle. So there is good, even when I reviewed the literature, Silymarin has better literature than SAMI. So this is a systemic review of so many 29, just give me 5 minutes please, 29 RCTs, 3846 patients. The Silymarin, when used in the dose of 140 milligram to 420 milligram, it exhibits potential for hepatoprotection by ameliorating liver enzyme levels across diverse conditions. So Silymarin, I personally feel Silymarin is better than SAMI for many reasons. It has pro-apoptotic, anti-inflammatory and antioxidant activity. So I will skip, there is a lot of data on Silymarin. And so I will just come to the latest one. So this is the latest study, 2023, administration of Silymarin MASLD. So what they said, Silymarin regulates metabolism, reduces liver injury and improves histology. So it also has a role in MASLD and it is very less studied, and we can have some studies of Silymarin in our part of the country. So Silymarin is very important. Another thing is metadoxin. I will just skip. Metadoxin is a drug with antioxidant and detoxifying properties. Improves liver function in ALD, and this is an old study of metadoxin in colic patients and with beneficial outcome. Glutathione is coming up fast. Glutathione is formed like glutamate, cysteine, and glycine. I will just skip the names. It has role. So this is a gut article from 1965. So glutathione was thought to be helpful in hepatic cirrhosis in 1965, but it was never followed up. And glutathione, some small studies of 110 patients shows improvement, oral glutathione in alcoholic liver disease. When it given with NAC and glutathione together, it helps in chronic hepatitis B patients. And there, if we give IV glutathione in alcoholic hepatitis, in the control group versus cases group, the significant improvement in liver enzymes and bilirubin level. So to summarize, theoretically, evidence to show role of glutathione in liver disease. However, there are limited studies, again, no large randomized control trial, and both IV glutathione and oral glutathione can be used. Quickly, herbal agents, I will not go into liver 52 and all, but one study from Dr. Phillips said, if you add herbal agent in these patients, they will die early and their survival is less. So it's a big, big no to add herbal agents in our practice. Coffee has a good role. It is antioxidant, immunomodulatory, and anti-inflammatory. And there are data which says that at least 3 cups of black coffee per day is hepatoprotective. And these are the clinical trials of natural products which are in pipeline. This is from latest article in 2024. Artichoke 8 probiotics, again hepatoprotective, 11 trials. Chicory 9 trials, algae, milk thistle. So all these trials are in pipeline. This is an article of natural products. So turmeric, vitamin D3, green tea, cinnamon. So all this is in pipeline. So there are so many things. But these guidelines, no one, these people who tell us what to do sleeps over them. ASLD, EASL, PASL tells nothing about these drugs. What should we do? But there are so many studies going on. So in the last, NAC in acute liver failure and UDC in cholestatic liver disease have proven roles. Consumption of 3 or more cups of black coffee may be encouraged. Glutathione, semi, and silymarin might improve liver biochemistry, but it does not translate into clinical and histological response. Herbal agents themselves can cause liver injury. A large RCT on above agents and some form of guidelines from liver bodies is the need of the hour. Thank you so much.
If we have to write one of the hepatoprotective agent as a placebo, which one should we prefer?
So to be very frank, you can write whichever company guy you like the most. This is the answer and everyone will agree with me. So the guy who comes to your office with that booklet and iPad these days, and you like his face, you can write. So till Dr. Roda and Dr. Nand or Dr. Ashish and Dr. Chawla will give a guidelines in MASLD that this patient ALD, should we use UDC or not, we don't have an answer on this platform. And the answer is that it is subjective. It is totally subjective. This is an open gray area. You can do whatever you want. The only message is they are not harmful. You can go ahead. If the patient pocket permits, you can write semi, glutathione, everything together also.
Thank you.
Varun, here.
Yes, sir. Hi, sir.
Just one line message which I would like to convey. If you are writing any of these hepatoprotective to your MASLD patient, you are doing disservice. Rather than advise them to lose weight and do exercise.
I agree, sir. But so hepatology is beyond hepatologists and gastroenterologists. There are so many physicians, BMS doctors, NIMA doctors, even gynecologists who write these drugs even without sending the patient. So we have to have something. So the message I would like to give you, because you are the guy, so you should have some guidelines from MASLD that how should we go about these drugs in future. Thank you.
We would like to invite on stage our next speaker, Dr. Shalimar.
Okay. So from moving on from I think Varun has made a very important point, is that we need to think about what he said. You need to have guidelines, because the use of these medications is quite rampant in our country. So now moving on to something more important, where we have some data, that is expanding indications of TIPS. The use of TIPS is predominantly being used for indications where you're going to reduce the portal hypertension and thus leading to reduction in the complications. The complications where TIPS is used includes variceal bleeding, either as preemptive or secondary prophylaxis, refractory ascites, hepatorenal syndrome, hepatic hydrothorax, portal vein thrombosis, Budd-Chiari syndrome, sinusoidal obstruction syndrome, ectopic varices, and pre-op portal decompression. Let's look into the data, what is there. When I talk, I'm going to also introduce you a few terms which come along with this tips is P-tips, which is the preemptive tips, salvage tips, PVR tips, and destination tips. Remember those? We're going to talk about each of these in the subsequent slides. The use of tips, early tips, which is also known as preemptive tips or P-tips for acute variceal bleeding, used within 72 hours, preferably within 24 hours, in a select group of patients who got child status B with active bleeding, child C, and those who got an HPPG more than 20. Use of early tips is associated with significant reduction in mortality and also leads to reduction in their rebleed rates. So if used in a select group of patients, P-tips is associated with improved outcome compared to the standard therapy of acute variceal bleed that includes just banding and beta blockers. Expanding the scope of P-tips or tips is the use of tips in acute and chronic liver failure. We know that the mortality in acute and chronic liver failure is quite high, and that too specifically in a subgroup of patients who got acute variceal bleed. This study from the UCL London shows that in the patients who got ACLF used with acute variceal bleed, tips when used in a select group of patients is associated with better survival compared to those ACLFs whom tips is not used. So we need more data, but then some data to suggest use of tips in this particular group of patients will also be associated with better outcomes. Refractory bleed, that's a salvage tips. When you're not able to control bleed and you do a tips issues, it is associated, this group is associated with high mortality. Important to notice what this study showed us very clearly in the group of individuals where you should not use tips. One is those who got a high lactate, that is more than 12, and a MELD score more than 30. CTP scored 14 to 15, these are futile tips. But if you got patients who got lower MELD scores and lower lactate levels, these are associated with better outcomes compared to those who got high MELD and high lactate. Moving on from variceal bleed, which is from the esophageal varices, to the use of tips in patients with gastric varices. This is our randomized controlled trial where we showed that addition of either BRT or tips after the glue application is associated with improved gastric variceal rebleed rates and mortality, but then overall mortality was not different, again suggesting that tips when used as P-tips for gastric varices is also associated with improved rebleed rates in this subgroup of patients with gastric variceal bleeding. Recurrent ascites, refractory ascites, only one randomized controlled trial available which showed that use of tips is associated with reduction in the requirement of large volume paracentesis, hernia complications, and reduced hospitalization rates. Coming to our PVR tips, that's one which is being used in the liver transplant setting. When you got portal vein thrombosis, we do find that surgeons find it difficult to do anastomosis. And here comes the role of possible use of tips for improving the recanalization of portal vein thrombosis. What this study, which is a retrospective analysis of a small sample size study, shows that use of tips, which is the PVR tips over here, led to improved resolution of portal vein thrombosis, and during the time of surgery, they allowed better end-to-end portal vein anastomosis. Surgical aspects were better, but important note, this study showed us that there was no survival difference between the two groups. But then, yes, could be used in select patients. Refractory hydrothorax, this meta-analysis showed that use of tips in such patients leads to higher rates of complete resolution in almost like 56% and a partial response in almost 18% of patients with refractory hydrothorax. This meta-analysis done by Professor Kamat's group showed that use of tips in patients with for HRS, this HRS has undergone every 5 years we have a new definition, so I really don't understand which group are we talking about. This study did a meta-analysis which had actually patients with HRS1 and HRS2, showing that there is a survival benefit and improvement in renal functions with the use of tips, but still we need more data. This is a group of patients who got high mortality, high complications, so a selective choose choice of patients is very important. Important note is that patients who got an underlying parenchymal renal disease, they are not to be considered for TIPS. Our data recently, which looked at 3 centers in India, 318 patients with Budd-Chiari syndrome showing use of TIPS associated with a reduction in further decompensation of these patients and a survival rate at 10 years reaching almost like 80% in a cohort of 318 patients. TIPS can also be used in patients with PSVD, which is a new term for idiopathic or NCPF or NCPH, which includes that group. What this study showed is that for complications, including the variceal bleed and the ascites, which these patients had, they fared better than those patients with cirrhosis. They had a better outcome and less rates of overt hepatic encephalopathy when used in these patients compared to those patients with cirrhosis. So, in select indications, you can consider TIPS in patients with PSVD also. Another concept which is not very new but then has been there in the literature is destination TIPS. That means you've reached your destination, that is without a TIPS we know is a bridge to transplant, and over here you have reached your destination. That means without transplant you've reached a compensated state and you do not need a requirement for the liver transplantation. And what this study has showed is that those patients who had low MELD and those remain stable, these could be patients who really may not need transplant over time, and then this is the concept which has come up and which has been given as is the destination TIPS. This individual patient meta-analysis showed that the studies included is randomized controlled trials and patients who were included in retrospective and prospective studies. Important to note that the authors over here did a propensity score matching, and what they have showed is that use of TIPS led to reduction in the further decompensation and improved survival in patients with cirrhosis and portal hypertension and complications. And the group of patients included in these patients were predominantly patients with refractory ascites or those with variceal bleeding. Can it be used for improving nutrition? We know that sarcopenia, poor nutritional status, is associated with poor outcomes. What this review showed us that, yes, there could be some improvement in nutritional status of patients with use of TIPS. And important to note is that patients who had sarcopenia had better outcomes with use of TIPS. So, but we still need more data in this subgroup of patients. Expanding beyond our limits, that's use of TIPS in patients with age above 70, this study showed that there was no difference in the mortality between the two groups. Yes, it can be considered in select patients beyond 70 years also. We need still more data in terms of use of TIPS in hepatopulmonary syndrome, portal hypertensive gastropathy, use of preoperative TIPS before abdominal surgeries, use of HCC, benign, bland, portal vein thrombosis. Can it be used to improve the status of patient? Ectopic varices, EHPVO, portal cavernoma cholangiopathy, impact on waitlist mortality and post-survival. On these subgroups, there are case reports, small series, but still we need more better data regarding before we can recommend its use in routine clinical practice. There are contraindications which you need to remember. Not every patient can be put on a TIPS. There are contraindications, and if you move beyond boundaries, beyond your limits, you're going to have more complications in your patient. So do keep in mind that these are complications which need to be kept while considering a patient for TIPS. So take home points, TIPS remains a cornerstone intervention for managing complications of portal hypertension. Timing is important to maximize the benefits and avoiding adverse events. Decision for TIPS is based on case-to-case basis and on a multidisciplinary approach. Future research needs to focus on refining patient selection criteria, new indications, optimizing post-procedure management to optimize the maximum benefits with minimizing risks in these patients. Thank you.
Thank you, Professor Shalimar. It's a very crisp presentation. Can we have some questions from the audience and my chairperson colleagues?
Many times when we go ahead with the TIPS and patient lands up into hepatic encephalopathy, what preventions we can take, or when exactly should we plan for your TIPS reversal based on the severity, so that we are not too late and we are not too early?
So for this subgroup of patients, when you're subjecting to TIPS, HE definitely is a very important complication, going up to almost like 30 to 40% till the end of 1 year. Options available include, one is you start them on preemptive therapy in terms of rifaximin. There's a very good trial that suggests use of rifaximin helps prevent that. You can use other like disaccharides, lactulose. Very interesting study came up on use of probiotics last week in Liver International, again showing a significant reduction of post-TIPS hepatic encephalopathy. Important is to choose your patient right. Sarcopenia is another important factor which plays a role in hepatic encephalopathy post-TIPS, which we tend to ignore. So choosing a right patient and optimizing the medical therapy. Yes, use of small diameter tips in terms of either 8 mm or even some cases you can use a 6 mm can help you. In those patients who got refractory HE, yes, reduction of tips by placing another tip stent within that can help you reduce the diameter, and these could be the options for managing. If you don't get benefit with all these, and transplant definitely remains on the horizon for as a management for these patients. Thank you. Thank you.
Thank you, sir. So coming to the final leg of today's evening, state of the art lectures, and I would request our moderators, Dr. Mayank Gupta, Dr. Amit Miglani, Dr. Avinav Arora, Dr. Bharat B. Gupta, and Dr. Rahul Pathak, and the chairpersons, Dr. Ashish Raj Bhandari, Dr. Harsh Udawat, Dr. Ajit Khanal, Dr. Binod Karki, and Dr. Ashmit Chaudhary, and the speaker, Dr. Patrick Kamath.
Thank you. My thanks to Anil, Ashish, and Praveen for inviting me. I want to thank Paragenus, my friend and collaborator, for some of the slides I'm going to be using in this presentation. The time is limited and the hour is late, so just want to make a few points in this talk. So your first take-home message is going to be, you get ascites and edema because of sodium retention. We'll go over this in more detail. If there's water retention, you will get hyponatremia, and if there's renal vasoconstriction, you get the hepatorenal syndrome. So let's go over the pathophysiology of ascites. Patients have increased intrahepatic resistance as a result of cirrhosis, and that increases the sinusoidal pressure. For reasons I won't get into, patients with liver disease also have arterial resistance decrease, which is vasodilatation. This is sensed by the kidney as a decrease in the effective arterial blood volume. So for compensation, it activates renin-angiotensin and aldosterone to retain sodium and water, and retention of sodium and water gives rise to ascites. Now, as liver disease gets worse, there's a further decrease in systemic arteriolar resistance, a further decrease in the effective arterial blood volume, more activation of neurohumoral systems, more sodium and water is retained, and then you get refractory ascites. Even at a later stage, there is intense renal vasoconstriction, and this gives rise to the hepatorenal syndrome. So to summarize, renal dysfunction and cirrhosis, there's a decrease in arteriolar resistance causing vasodilatation, there's a decrease in the effective arterial blood volume, and as compensation, sodium is retained and sodium retains water, and you have ascites. There's renal vasoconstriction, which gives rise to hepatorenal syndrome, and you have water retention, which gives rise to hyponatremia. So this is the most important message from today. Now, the other important message I want to give you is the importance of urine sodium. It'll tell you the rate of ascites accumulation, the response to diuretic therapy, and its prognostic. And I really like this test. And so I Googled. In India, it costs 150 rupees to do renal sodium. I think it's way cheaper than many of the other tests that you're doing. So what does renal sodium tell you? So here, let's say a urine sodium is 100 milliequivalents per day. This patient will have slow ascites accumulation, and in 1 month, will put on 8 kilograms. On the other hand, if the urine sodium is less than 10 milliequivalents per day, that patient in 1 month will put on 30 kilograms extra. Now, this is on a US diet, which is 3.4 milligrams per day. Again, when I reviewed literature in India, this review says the average sodium intake in India is 11 grams, which is much higher in the US, but of course there's much more sweating here. So you will have to figure out what is the best urine sodium for your patients. So once you know that ascites results from sodium retention, how do you manage ascites? You can try diuretics and sodium restriction. This will restrict the sodium and water retention, and that will decrease ascites. If that does not work, you can try large volume paracentesis with albumin. Albumin works on the arterial blood volume and increases it, and the large volume paracentesis removes the ascites. So let's come into the management of uncomplicated ascites. So this is ascites which is responsive to diuretics in the absence of infection and renal dysfunction. So this is going to be most of your patients. Sodium restriction is effective in about 10 to 20% of the patients. And who are those who are going to respond? Those who have got a high urine sodium to start off with. Diuretics, spironolactone monotherapy is better than furosemide monotherapy, but a combination is better, but you have to monitor them carefully and you require more frequent dose adjustments. So again, coming back to urine sodium, let's say you have a patient on spironolactone 100 milligrams daily and furosemide 40 with uncontrolled ascites. The urine sodium is 100. Your options include increasing spironolactone, increasing furosemide, increasing both, scheduling weekly paracentesis, or discussing the importance of compliance with a low salt diet. And here's how we interpret the urine sodium. If the urine sodium is more than 90 and the patient has weight loss, this tells you this patient is diuretic sensitive and is adhering to sodium restriction. So, no change in management. If the urine sodium is less than 90, patient is not losing weight, this patient is diuretic resistant at the current dose, you increase the dose of diuretics. Or the urine sodium, like our patient I discussed, is more than 90 per day, not losing weight. This patient has to be losing weight if they're compliant with sodium restriction. And if they're not losing weight, they're not compliant with sodium restriction. So you decrease the sodium intake in these patients. It's important to know that patients get hyponatremia. And when they have hyponatremia, it's associated with hepatic encephalopathy, impairment in quality of life, neurological complications after liver transplantation. They are diuretic resistant when it comes to ascites, and they generally are a marker of a high-risk population. This is a population with frequent complications and poor outcome. So generally, hyponatremia reflects extreme hemodynamic dysfunction. So it is prognostic. There's very little you can actually do about it. If you try and do something about it, you're going to cause some problems. So, caution, your body is smart enough to figure out what to do about the sodium. Try messing with it as little as possible. So except in clearly depletional hyponatremia, avoid sodium replacement in these patients. Just leave these patients alone. It's a marker of poor prognosis. Some tips for management of ascites. Start with spironolactone 50 to 100 in most patients. It takes 4 to 5 days for the drug to work, so don't increase the dose early. So typically increase it every week. You will add furosemide if they come to you with tense ascites or if they are refractory to spironolactone alone and if they have low lymphedema. The adequate ratio is 100 to 40, though you might change this. Ask them to record their weight daily if possible. They should be losing about 500 grams per day. If they have low lymphedema, they should be losing about 1 kilogram per day. Your urine sodium goal is greater than 90 milliequivalents per day. And remember, diuretic therapy is limited by renal dysfunction, hyponatremia, I've talked to you already about that, hyperkalemia, encephalopathy, and gynecomastia. So, when you're using spironolactone, use it with caution when the creatinine goes up, because these patients are prone to hyperkalemia. So go easy on your dose of spironolactone. In fact, once reaching that level, consider using little more furosemide in these patients. Older patients or patients with chronic kidney disease have an impaired response to diuretics and are prone to acute kidney injury. Go very slow on diuretics in older patients and if they have underlying kidney disease. When you have pleural effusion, these goals of 500 grams and all don't hold good. They cannot mobilize more than about 250 per day. So again, don't be aggressive with diuretics if they've got pleural effusions. If they have gynecomastia, I don't know what drug you have here. You can start eplerenone, smaller dose. It works just like spironolactone. Titrate in 2 to 4 weeks to about 50 milligrams once daily. And you have to adjust the dose based on potassium levels. So next take-home message, use diuretics extremely carefully because side effects are common. And then we come to tips. Shalimar gave you a really good talk on tips. It decreases sinusoidal pressure, it increases the effective arterial blood volume, and therefore decreases ascites. But there's a problem with tips. You have to be careful with tips. The older I get, the more reluctant I am to use tips. It is effective, but it may induce hepatic encephalopathy in a significant proportion of patients. Be very careful in older patients because they get refractory encephalopathy and the person looking after them is the spouse who's also equally old, and they find it very difficult to manage patients. So once they get encephalopathy, they'll say, "You never told me it was going to be so bad." The caregiver will also say, "You never told me it was going to be so bad." So be very careful in these patients. Not only that, the physicians who recommended tips for them may not have explained everything to them other than encephalopathy. They can get worsening liver failure, they can get pulmonary hypertension and lower limb edema later. So not everything is explained to these patients. And so I think be very careful with this, and you need better studies because you can very strongly recommend it. Yes, we recommend, but not that strongly. And then finally, we come into the acute kidney injury in cirrhosis. So, what are the precipitating events? Vasodilators, or large volume paracentesis without albumin infusions, or infection will cause more vasodilatation. If you have diuretics, diarrhea, or hemorrhage, you have a further decrease in the effective arterial blood volume, both of which will activate neurohumeral systems, which will cause renal vasoconstriction and renal dysfunction. So watch all these patients carefully. Especially even a single dose of non-steroidals will increase vasoconstriction. So any of these factors that I told you about, be careful about them because they can lead to renal dysfunction and acute kidney injury. So when you see a patient with acute kidney injury, there are really 5 essential steps. First, on day 1, is this acute kidney injury and what is the stage? Also on day 1, look for precipitating causes and try and remove them. Albumin administration in some patients. And then day 3, if they have not responded, you need to know what the cause of the acute kidney injury is if they have not responded to albumin, and you have to figure out how to treat these patients. So 5 steps. So what is the management? Patient has cirrhosis, so liver transplantation. Decrease in the effective arterial blood volume, albumin. They have vasodilatation, so you can use vasoconstrictors in these patients. So here's the approach to acute kidney injury in patients with cirrhosis. If the creatinine goes above 0.3, but less than 2-fold, and less than 1.5, this is a group you don't have to be that worried about. Try risk factor management, hold diuretics and beta blockers, non-steroidals to be discontinued. and see how they do. If that resolves, then you monitor these patients. If they don't resolve, then look again, have you managed risk factors? And then consider albumin in these patients. But again, be careful about albumin because they have a risk of pulmonary edema. If it goes above 1.5, or if there's a greater than increase in twofold in the serum creatinine, you will start albumin right away. If they resolve, monitor these patients. If they don't resolve, look at urinary biomarkers. If they're consistent with acute tubular necrosis, renal replacement therapy. If it's consistent with hepatorenal syndrome, vasoconstrictor and albumin. And if you're not that sure about it, try vasoconstrictor and albumin with renal replacement treatment on an individualized basis. So whom would you use renal replacement therapy in? Acute tubular necrosis with a transplant candidate, renal replacement therapy till transplant, and they may require both a combined kidney and liver. If they're not a transplant candidate, a very limited role. HRS-AKI, transplant candidate, yes, renal replacement therapy to transplant. Not transplant candidate, be very selective. The occasional patient with alcohol-related hepatitis, we may use it. Very often you're not sure about the etiology. Again, transplant candidate, renal replacement therapy till transplant. Non-transplant candidate, a limited trial of renal replacement treatment. So the decision for renal replacement therapy depends on etiology and transplant candidacy. So my take-home message is a decrease in effective arterial blood volume results in sodium and water retention and renal vasoconstriction. Use renal sodium, urine sodium monitoring is simple, cheap, and helpful. Sodium restriction and diuretics in most patients and large volume paracentesis. Use TIP sparingly and albumin and vasoconstrictors for AKI management. Thank you.
I think this has been a masterly presentation by a master teacher.
No.
You are a master teacher.
Thank you.
In fact, I am lucky that I was mentored by you.
Yeah, I remember you long ago. Yeah.
Okay. Now, one thing I wanted to ask, like most of the slides they mentioned about furosemide. In India, we use quite a bit of torsemide. Any
yeah, so the question is, other than furosemide, what has been proven to be used? So in all studies, it has been a combination of spironolactone and furosemide. Torsemide is much more severe in terms of the renal loss of sodium. So spironolactone, 3% is retained. With furosemide, it's 30%. And with torsemide, it's about 50%. So it's a very rapid loss. So again, you have to be very careful in these patients. So in the very occasional patient who is refractory to furosemide, you can use it. But otherwise, good old drugs are the best.
What is the standing of Levine shunt and alpha pump? Because in most of the European countries, alpha pump is being used for management of.
So the question is, what is the use of the alpha pump? I led the US study and it has been approved by the FDA, but when it comes to using it in clinical patients, we have not used it at Mayo. At Mayo, I've said we are not going to use it, okay? There are many problems with it. It's a good device for extremely selected patients. You have to monitor them very, very carefully. We had a monitor, we have a nurse looking after them if you outside of very good monitoring facilities, I don't think it's a safe device. So I don't recommend alpha pump use. We are late.
Sir, role of midodrine.
Yeah, so you have to look at the question of midodrine increases mean arterial pressure a little, and so the question is it effective? So we know this is the midodrine albumin study which showed it was not effective. Generally, we don't use it. Remember using beta blockers on one side, you're using midodrine on the other side. You're better off discontinuing beta blockers in these patients.
Yeah, I wanted to ask the same question on midodrine. So you answer.
Oh, thank you.
Dr. Question. It's right here.
Oh.
So Dr. Kamath, instead of using urinary sodium, can we use the ratio of urinary sodium to potassium?
Yeah.
Would it not be more convenient and clinically easier to use?
Yeah, so actually that's a very good question. So if you see on my slide, you can use either urine sodium or urine sodium to potassium ratio. Anything more than 1 is good natriuresis. So if it's more than 1, you've reached target. Yeah, good. That's a good point. Thank you.
Thank you, Professor Kamath. Thank you very much.
We would like to invite our next speaker, Dr. Keen Wang Win.
Congratulations to Professor Anil Arora and the team for being able to conduct such a highly prestigious academic conference. And also, thank you very much for inviting me. The MASLD, as previous speakers have mentioned, was formerly known as NAFLD, and MASH is NASH, and increasingly prevalent due to rising obesity and the metabolic syndrome. Because MASLD is mainly due to the diabetes and the obesity. If you look at the world data, about 30% MASLD and 5% MASH. It is expected that by 2030, MASLD will be around 56%. MASH is a progressive disorder ending up in cirrhosis of the liver. It is accompanied by the advanced many diseases like 3 times more in the all-cause mortality, 4 times coronary events, and 11 times liver-related mortality. The MASLD liver fibrosis is strongly associated with the risk of severe liver disease and the liver-related mortality. And MASLD is steatosis is just fat, no inflammation. MASH is fat with inflammation. Cirrhosis is with the fibrosis. MASLD, just fat only, is 25%. With the inflammation and fibrosis, 3 to 5%. With the fibrosis, 1 to 2%. And MASLD is, the problem is usually associated with the obesity, insulin resistance, hypertension, dyslipidemia, and you can see obesity, T2D, dyslipidemia, associated factors, many percentages associated. Global estimated MASLD mainly in the diabetes and the obesity, MASLD all stages of significant fibrosis or cirrhosis. The treatment traditionally focuses on lifestyle, metabolic surgery, pharmacology treatment. I will not be dealing with the lifestyle changes or metabolic surgery. I will focus my presentation today on the pharmacological treatment. There are EASL or the Latin America guidelines for the NILDA, non-invasive liver disease assessment methods, and the indications for this treatment, but I will not also be touching on those areas. MASH management is to have the improved long-term clinical outcomes is cardiometabolic improvement, decrease in body weight, improved lipid profile, improved glycemic control, cardiovascular parameters increase, and on the MASH-wise, 1 is reduction in the fat content, 2 is halting the fibrotic process. Not only that, we want to reverse the fibrosis. The main pathogenesis is the insulin resistance. This is a very busy slide. I do not want the audience, I do not expect the audience to be able to read, but the fact is that MASLD was formerly studied 1-hit theory, 2-hit theory, multiple hit theory. Now there are many aspects where you can intervene, and there are many drugs, and you will probably, I will later show, about 70 drugs are in the stage 1 and 2 trial stage. Recently, resmetirom thyroid receptor beta agonist was approved by the 14 March 2024 for the treatment of the F23 MASH. And quite recently, about 3 weeks ago, semaglutide GLP-1 receptor agonist injection 2.4 was approved for the treatment of the MASH F23 without cirrhosis. Other imagings were also on the pipeline, and currently, as I've just mentioned, resmetirom, 14 April 2024, semaglutide injection 2.4, 15 August this year, 3 weeks ago, 2024, and the other 5-6 line drugs are in the phase 3 and 25 in the phase 2B and more than 70 in the phase 1-2. Resmetirom is just briefly, the MASH liver has intrahepatic hypothyroidism. So resmetirom will have a increased mitochondrial biogenesis, increased lipophagy, and it inhibits the lipolysis. Resmetirom has NASH resolution with no worsening of fibrosis, fibrosis improvement with no worsening of NAFLD, and FDA approved 14 March for the treatment of the MASH F23. The indication is when the image NILDA is between LSM 8 and 15, liver histology is matched with F23. You're not supposed to treat those with the LSM more than 20, MRE more than 5 kPa, but however, it may be used by the expert in fibrosis treatment and expert hepatologists to treat cases beyond those criteria. As I have mentioned previously, during the trial, the hepatotoxicity was a concern, and the pharmacovigilance on the hepatic injury should be strongly emphasized, and you should test the hepatic function before treatment, 3 months, 6 months, 12 months. And also for the stop-in rule for the resmetirom, you need to test the thyroid function, lipid profile, NILDA. NILDA should be done before treatment and after 1 year. So, stop-in rule. After 12 months, worsening of the NILDA and consistent increase in the ALD, stop it. If there is improvement in the NILDA, VCT more than 25% improvement, MRE more than 20%, then you continue. In between borderline values, you need to pen in and you need to assess whether to continue or not. And then I move to the semaglutide, which has 4 main actions. One on the brain, that will reduce the food intake, increase weight loss, and decrease liver lipids. On the pancreas, the insulin secretion will be enhanced, and adipocyte will be reduced. And it will increase the insulin, at the same time, it will reduce the glucagon. On the GI tract, it will delay the gastric emptying, and it will also reduce the chylomicron secretion. Semaglutide, the famous trial is the ESSENCE trial, and it's also MASH resolution with no worsening, improvement in liver fibrosis, no worsening of MASH. In fact, the semaglutide injection 1 milligram was approved in 2017 for the T2D, and 2.4 milligram approved in 2021 for the obesity. But it is approved for the MASH F23 only 15 August, 3 weeks ago. Oral semaglutide, I don't know about the India. In our part of the Asia, South Asia, Malaysia, Singapore, Thailand, we use semaglutide widely used for the diabetes as well as off-label use for the management of obesity. In fact, FDA approved oral semaglutide in 2019, 3 milligram, 7 milligram, 14 milligram, produced by the Novo Nordisk, and it uses the SNAC absorption enhancer to allow the gastric uptake and significant A1C reduction and moderate weight loss. But with our experience, with my experience, it has very effective in the weight reduction. Professor, you will see me about a year ago, much better. I took 40 milligram, I lost 65 pounds within 6 months. I'm still taking it. And one in is C-cell pancreatitis. One big news, high-dose semaglutide, you call it Wegovy tablets, accepted by the FDA for the consideration on the May 2025, and the result will be announced end of this year. And the next most popular drugs, therapies are the combination therapies. Like a GLP-1 or the FASNI, it is phase 3 trials, and GLP-1 plus Efixa plus ACC, semaglutide plus cilofexa plus fibrostat, that is also in the phase 3 trial. What about the regional perspective? What in our region? If I have to quote the EPASL epidemiology, it is found to have the same as world global trends. We are the same as the world trend and EPASL. So, how about treating? When the unique factors to be considered in our region is the ethnic differences in lifestyle, different in diet and concepts on life, and socioeconomic factors affecting diagnostic facilities, prohibitively expensive MASLD, MASH therapeutic drugs, barriers against lifestyle monitoring strategies, various diet programs. You mentioned for the working group, they're surviving for day to day. You are telling them the Mediterranean diet with that, this diet, that diet, they will never listen. Exercise and physical training also not relevant in my country. 70% of the people living in the situation where there's no electricity, no safe drinking water, you are telling them for the training, physical exercise and diet, that will be useless. So the practical and real world suggestion is start with a very simple thing. Treat cardiometabolic risk factors, treat hypertension, treat diabetes, treat dyslipidemia. Simple weight loss targets, simple diet plans, check alcohol intake, check hepatitis B and C status. Use low-cost NILDA, non-invasive liver disease assessment in primary care. FIFO in every one with a risk, elastography if available. What to prescribe? Statins, metformin, pioglitazone, vitamin E. Arun Sanyal has recently mentioned, don't forget Aristo, pioglitazone and the vitamin E. Still not very strong data, but still useful. And luckily in our part of the world, I don't know about India, generic semaglutide and generic resmetirom are available. And you can this be around 20 to 30 US dollar per month, and we can use it. So in conclusion, most novel MASLD and MASH therapeutic agents focus 1, metabolic improvement, reducing the fat. 2, reversing the inflammation. 3, preventing or halting or preventing or reversing the fibrosis. So resmetirom, 14 March 2024, semaglutide injection, 15 August have been approved by the FDA for the treatment of the MASH F2-3 without cirrhosis. 5 candidates are currently in phase 3 development, and the combination of GLP-1 RA with other approved treatment is the next logical step there are many ongoing trials. A combination is the most popular mode of treatment for the MASH. GLP-1 will be the backbone of the treatment in increasing number of the MASH patients. So focus on the combination therapies, testing multiple pathways to reduce metabolic inflammation, fibrotic, personalized medicine based on metabolic profile, and ongoing trials to define long-term safety and outcome. Thank you very much.
Any comments, Professor Chawla? Actually, I was amazed to go through the literature. Even aspirin has been, it is being used for the management of MASLD. Some trial is going on, and phase 2 trial has revealed that there is a 30% reduction of liver fat in 43% of the patients. One of the very cheap alternative.
So I concluded that to save the life, use the cheapest drugs, which is not toxic, even though they are not very strong, they should be used.
And lately there is a lot of interest in NAC and carnitine and amino acid combination.
There are many things, many candidates.
Any comments from the house? With this, thank you very much.
Thank you very much.
For our last session for the day, we would like to invite our moderators, Dr. Sharad Malhotra, Dr. Richa Diwan, Dr. Saurabh Argal, Dr. Pradeep Yadav, Dr. Naveen Kumar, and chairpersons, Dr. Kalidas Biswas, Dr. Romeo Kansakar, Dr. Romesh Chawlani, Dr. Bimita Mahat, and our speaker, Dr. S.K. Tyagi.
That's a terrible photograph taken years ago. Everybody has thanked Anil for such a conference, but I'll thank Anil for holding on the bar and not getting it open, otherwise we would have had an empty hall. But so be it. Given 10 minutes to talk on this subject is extremely difficult, but I shall try. 15? Oh, thank you so much. I genuinely, from the bottom of my heart, want to dedicate this lecture, perhaps one of my last few, to a very dear friend of mine of 30 years, and many of you would know him, who passed away a couple of days ago, Sameer Desai. A gentleman I have respected for his vast knowledge in various subjects, and he's been something that I would have really appreciated to be. Sameer, I dedicate the next few minutes to you. I talk to all of you not just as physicians. I want to talk to you as colleagues in a journey which takes us to the threshold of death and life, of suffering and relief, and of anguish and of despair and hope. We all stand there practically every day. We are trained so much, and every day, like these conferences, we get trained to go through very complicated algorithms. We have actually perfected the art of, the genes. We've decoded the genes. We have now gone into the area of artificial intelligence, and we've become extremely competent in treating the person. But in this endeavor for perfection, I personally feel that we have actually forgotten. We've become excellent at the disease, the illness within the person, but I think we've forgotten to heal the person himself. Well, I shall take you through the topic of spirituality and medicine. And as Freud said, and I think he's the one basically all medical practices and treatments were in times immemorial were from spiritual leaders. Hospitals, the most initial ones in this world, were led by spiritual leaders or by religious leaders. Then in the earliest 90s, it was the first few books written by Freud which said, and I'll just quote a bit, religion and science are moral enemies. And Freud saw religion as an illusion, he wrote in his book called The Future of Illusion, and collective neurosis. And from the earliest times, even though healthcare was there, it was his two books, Civilization and Its Discontents and The Future of Illusion, that actually started the process of religion being dissociated or spirituality being dissociated from medicine. But within the experience of serious illness, there is an indelible connection between medicine and spirituality. And one doesn't really need too much of evidence. We just need to slip on a banana peel and say, oh God, it hurts. You don't have to be a religious person. You may be an atheist, but the first words that come out of you is, oh God. Because that is what we believe is going to help us. That is what we believe is our support, which will never leave us. The evidence demonstrates that the medical profession largely neglects spiritual dimension of patient well-being and illness. The word being wellness and health and heal. Well, the word heal actually means to make whole, and it's related to the word health, which is being whole. And being whole, and the definition of health itself, is not merely the absence of disease. Mind you, we might treat a person with a cerebral hematoma and get him all right and send him back to his house. But we've not taken away the fear that it might again happen. We might do a colectomy and leave a person treated with a colostomy or an ileostomy, but we've not treated the loss of courage or the shame that he has every time he takes off his shirt in front of his wife. Or for that example, the shame of a person walking with a limp and a right-sided or left-sided stroke. That is healing, when that we can get back to that person to walk with dignity despite the disability that he may have been left behind with all good treatment. And what helps then is his connect to the transcendence. And what is transcendence is something which is beyond physical. What is beyond physical is knowing yourself and being at peace with yourself, either through spirituality or religion, and the two are interrelated and can be used interchangeable. And therefore, there is a bit of a difference between religion and spirituality, because religion is bound as an organized system of beliefs and rituals and practices, whereas spirituality is not dogmatic. It can be practiced by anyone of any religion, and therefore spirituality can be a part within any religion, but religion can support spirituality. So the two are interrelated, but spirituality does not have any dogmatic foundations. It is just anything that gives you peace, pleasure. It could be singing, it could be walking alone, it could be a walk barefoot on dew-filled lawn or a garden. That could be spirituality. Of course, the commonest ones are meditation. But I have been given a topic of science behind this spirituality, and that makes it a little dull, but nonetheless it's important, and that's what's been given to me. And all studies. Science is based on studies, and the studies could be observational or interventional studies, but it always relies on data points and statistics, and the data points rely on measurable outcomes. Unfortunately, these measurable outcomes are not within our hands, and we've all seen it that over the period of time, these measurable outcomes keep changing, and so our idea, our concept of science and scientific outcomes keep changing. And in an attempt to verify the efficacy of spirituality and health, confining God or spirituality to randomized controlled trials or determine the divine intervention as a treatment by a p-value is not possible. And within the confines of these scientific trials, God would need to be measurable. Otherwise, science does not accept anything that's not measurable or reproducible. And if you have to reproduce God, then it's not God. So the two actually cannot go hand in hand. I will nonetheless try. I searched the internet and got 2,48,527 replies on this. Well-being being the highest, and we fed in the word coping with it, and they all talked about that spirituality helps you coping with adversity, it gives you hope and optimism, those who are more spiritual. It is a positive monitor, and these studies I don't have to repeat, you can read them, are all from the net and are all from studies that have been conducted, and I have given you a little index at the bottom. But why should you and I, why should any one of us be wasting our time talking about spirituality? It is because healing is more than just curing. Mind my words. Healing is just not the same as curing. It's the fear, getting the fear out of a person, I told you. It is giving dignity in the face of disability is too much. It's not just discharging a patient, saying better or recovering. Spiritual distress like fear, guilt, abandonment is also suffering, and it amplifies physical distress which we ignore because we only treat the visible half of a person's anguish or a person's disability or a person's illness. We forget what we can't see, what we can't measure, because that is what we've been trained into. We see the patients at the most vulnerable time, and mind you, we have the privilege of the patient telling us what it does not tell anybody else except the Almighty and you. And therefore, he is at the most vulnerable. He trusts you with whatever he says, and we need to know what he wants to tell us. And I'll come to that and the literature on that later. But it also protects us. In an era of burnout, bureaucracy, competition, being a bit spiritual actually gets you rid of all this. And it also reminds us of the sacredness of why we became doctors. And once you know the why to live, you can survive anyhow. And I add to it that those who remember why they became doctors survive any shift that might occur in our careers. Scientifically, the biological pathways that they have studied is the brain imaging, which shows the activation of the prefrontal cortex during this spiritual exercises or meditation, modulation of the limbic system that reduces fear and enhances resilience within ourselves, and immunologically, it reduces IL-6, CRP, and cortisol levels. These would be helpful mechanisms, and as with many emerging sciences which we've talked about today, they do need more rigorous research, but that's the food for thought. Because we cannot measure something, we tend to ignore it, or we can even troll it as unscientific. But ignoring it has led to fragmented care. As I told you, only half the visible part of the patient is treated. We have become good at treating disease but poor at treating the patient. Major institutions now have acknowledged that spirituality is being within the valid domain of health. They have now accepted that. As a matter of fact, patients who face severe illness or death, they question the meaning of suffering when they ask, why me? Why did I get it? They feel isolated, hopeless, deeply anxious when medical choices intersect with values and beliefs. Spirituality has been included as a part of quality of life. Guess what? When I went through all the spiritual leaders, the century, 15th century, 16th, 17th, 18th, 19th, at birth, this was what was the life expectancy, and Dalai Lamas of this period, they all lived above 90s. Not surprising, the ongoing Lama, Dalai Lama, where at birth, when he was born, the life expectancy was 70, he's crossed 90 already. Take the popes. All these years I have written you the 15th century to 21st century. The life expectancy I have shown you in the second column, and the papal life that they lived are all rising above, well above what was the average. Sir Aurobindo lived up to 78 when the life expectancy was 25. Ramana Maharishi in 1879 lived up to 70, life expectancy was between 26 and 28. Swami Chinnamayana in 1916 lived up to 77, life expectancy then was 30. Maharishi Mahesh Yogi in 1918 lived up to 90 when the life expectancy was 30, and Dayanand Saraswati in 1930 lived up to 85. Well, this is observational. I know science won't accept it, but can you ignore it? That's my question. Spirituality and seriousness literature review, well, it's here. The evidence, just go through this quickly because I'm going to skip it fast. I don't want to get involved in numbers because numbers are deviant and statistics can fool you. But factors considered important at end of life by patients are at peace with God and feel life was meaningful. When the same we compared with physicians, be at peace with God and pray and feel one's life complete, the patients had about 80% acceptancy. The physicians thought it's important by about 60 to 50%. That is the difference. Well, you can actually get into spirituality by using the tool, the HOPE tool and the FICA tool, in which you can talk to the patient, and they say it's recommended that you talk to the patient about the source of their hope, the organized religion they belong to, their personal spirituality, whether they practice it or not, and whether they would want any spiritual help in times of need. That's almost a good idea and is now being said is useful and should be introduced in care. Well, these have helped, and these are the statistics as how they help. Just go through them as fast as possible. And to integrate it into practice, be gentle, be open, practice deep listening. That's very important, which we are forgetting. It's not just their symptoms, but their stories that we have to listen to. We should not interpret their silence, because you'll be taught to listen to their history. But I'm telling you, the patient speaks the loudest in the silence when you've told him the diagnosis and his first verbal response. That silence speaks the maximum. Please listen to that silence. And at the very end, I just want to read a letter that was written by this tremendous Mike Tyson, a boxer, and he said, and I am not here to impress anyone. I have been the champion, I have been the villain, I have had gold around my waist but nothing in my soul. Now I just want peace, everything else is noise. I grew up without love. I didn't learn kindness. By 13, I was arrested 38 times. By 20, I was the youngest heavyweight champion in history. I had money, fame, mansions, private jets, but I couldn't sleep. I couldn't breathe. At 40, I started asking better questions. Then how do I win? But why was I fighting is what I started asking. And the truth is, I wasn't fighting any other guy. I was fighting myself. My fears, my own shame was what I was fighting. Now at 59, I'm not chasing anything. I grow mushrooms, hug my pigeons, walk barefoot on grass, and I cry sometimes for no reason at all. I talk about forgiveness. I don't need the roar of the crowd. I just want to tell the truth and die knowing I broke the cycle in which I was living. I want you to know that greatness is healing. Healing yourself. The toughest man in the world became a gardener. That is real victory. Well, gentlemen, the most important thing we offer our patients is not knowledge, it is ourselves. Thank you very much.
Well said, Dr. Tyagi. I think nobody can argue that because everybody is talking about spiritual health also. And it's not end of life. We have seen people who are very strongly grounded in any kind of spirituality, religious or non-religious even. They do much better. Their outcome, their healing, their stoicism in accepting illness, in accepting treatment is always much better as compared to those who don't address these issues. So I've seen it myself when patients are grounded, they were spiritual, their outcome was much better. It was not just end of life issues, it was even otherwise recovery from illness.
Thank you for your endorsement of my thoughts and my lecture. And I'm sure there's very little. SP wants to say something?
Nothing, I agree with you entirely because we have similar views. But don't you think God is only in fear you remember God?
And that is the fault.
Yes.
Whenever somebody dies, we say, may his soul rest in peace. We never let him rest in peace when he's alive. What I'm trying to tell you is, don't leave God or spirituality for the next generation to, crop up, get their head bald and to have a 13-day prayer for you. Do it now, man. If you have to go beyond the transcendence, start doing it when you are alive. When you are dead and gone, who cares for that carcass?
Second thing is, most of the people in Netherlands are atheists now. They don't believe in God.
So be it.
Are they unhealthy?
So be it. I'm not saying they are unhealthy. I'm saying people need help.
So whatever
People don't need statistics. People need, when you see somebody dying, a part of spirituality is whether you can bring that person's moments at peace. It's not religion. An atheist, when you use the word atheist, it is whether he believes in God or not. I differentiated religion from spirituality, even though you and many others tend to combine it together. An Islamist person can walk on barefoot, can sing, can meditate, can keep quiet with the Quran open. A Hindu can do it with the Gita open. That is spirituality.
So that is what we were discussing outside the hall, that you should enjoy your life. That's
yes,
more important.
I have.
Sir, one sec, sir. This thing about the God-men, is it because of their spirituality or is it because of the increased medical facilities that they are getting? Because the two most spiritual person from the place where I come from, Sri Ramakrishna and Vivekananda, one of them died at the age of 39 and one of them died at the age of 50.
And that was much before. That was much before. If you take the overall average, you are a statistician. If you take all the average, you'll realize the majority of them lived long. And what you are saying is whether it was health or not. The Pope died He received excellent medical care. But every time he got out of that at the age of 90, when we have a patient in ICU being admitted for the third time on a ventilator, what do we tell the families? There's little chance of him coming out. He came out, he addressed from the Vatican his believers, and it was only 20 days after that he died. That's the part of it. Now we can joke about it, but I said yes, those who don't believe, troll. Thank you very much.
Thanks, sir, for such an enlightening talk. Now for the last lecture of the evening, I would like to welcome on the stage Dr. Adrian Rubin.
Well, that's a tough act to follow. I want to thank Dr. Arora and Dr. Kumar and Dr. Sharma for giving me the privilege of addressing this wonderful conference of scholarship and conviviality. But when I look at my watch, 10 o'clock at night, I'm reminded of a peer in the British House of Lords who dreamt he was making a speech to the House and got up, woke up, and found that it was true. And so that's really the mood in which I find myself. All right, I'm going to talk about the negative effect of climate change on liver disease. And I leave you here my email address, so anybody who would like a copy of this presentation can write to me and I will gladly give it to them, because I'm including a lot of information that you may already not be familiar with. I also want to explain that I am a co-representative for what is termed the Multi-Society Task Force on Environmental and Practice Sustainability. I'm the representative of ASLD. And here you can see the Multi-Society Task Force, the members of it, the four from ASLD, ACG, AGA, ASGE, and then the latest group that joined are the pediatricians. Here is the primary achievement, that is the writing of a multi-society strategic plan on environmental sustainability and practice sustainability. And here is one figure from that publication which deals with climate change, digestive health, healthcare needs, and there's some areas of possible areas of intervention. Here are a few of the other projects that we have on hand. Education, indicators for sustainability, single topic symposiums, and so on. Now, this photograph is both poignant and iconic. It shows a mother polar bear sow, as they're called, with her cub, stranded on an ice floe that broke off prematurely from the ice cap. The definition of climate change is significant and lasting changes in the Earth's climate that ranged anywhere from months to decades. And most of it, as we'll see in a moment, is human-induced global warming, driven by an increase in what are known as the greenhouse gases, carbon dioxide, methane, nitrous oxide, and the chlorofluorocarbons that are used in aerosols. These are due to the burning of fossil fuels, deforestation, agriculture, and industrial processes, and the use of CFCs in aerosols. This was first recognized in the late 19th century by Sven Arrhenius in Sweden and the British engineer Guy Callender. In the 1930s and then later in the 50s to 70s, concern arose over the environmental effects of rising carbon dioxide. President Lyndon Johnson, science advisor, warned about the marked changes in climate due to increased carbon dioxide from burning fossil fuels. The US Academy of Sciences issued the Charney Report with the same warning. And in the 1980s and 90s and beyond, we saw the effects of this: retreating glaciers, changing ecosystems, species distribution, and so on and so forth. And in 1988, the UN founded an agency or a committee known as the Intergovernmental Panel on Climate Change, the IPCC, and this panel issues various pronouncements from time to time. In 2015, what was known as the 21st COP conferences, a maximum global surface temperature of less than 2 degrees Celsius was proposed. Actually, preferably would be less than 1.5. And here are two other examples of the effects of climate change. Antarctic ice is shrinking, iconic emperor penguins are in peril, and Antarctic seal numbers are in decline. Now, how does this happen? What is the greenhouse effect? How do the greenhouse gases cause this effect? Well, you can see that the greenhouse gases shown below come from aerosol inhalers, cattle, fertilizer, gasoline use in agriculture, and so on. And what happens is the loss of ice and snow leads to less reflection of sunlight from the Earth into the atmosphere, and then the greenhouse gases trap the warmth that comes from the sun, and this raises the temperature of the environment. Now, the causes and consequences of climate change are mostly from human activity and some natural activity. Approximate contributions to global greenhouse gas emissions are from energy production, such as electricity and heat from fossil fuels, as we've already mentioned. Agriculture and livestock are actually deleterious because they emit methane and carbon dioxide, and also livestock manure pollutes rivers. Transport, buildings, land use and forestry contributes more, as you see the percentages, and deforestation, of course, reduces photosynthesis and absorption of carbon dioxide, which now contribute more to greenhouse gases. The disposal of waste is another contributor, notably by healthcare, of which 15% is actually hazardous. And these data are derived from the IPCC. It's salutary to remember that emissions are contributed by the healthcare industry as well, to the extent of 5 to 10%, as if the healthcare industry was the 5th largest country on the planet. And as you see, the origin of these greenhouse gases are from boilers, medical gases, vehicles, waste, energy purchase, the supply chain, and actually patient and staff travel account for 45% of emissions. Now, the causes and consequences of climate change are shown here, and they're ranked in that graph by severity: rising global temperatures, polar ice and sea level rises, extreme weather events that we've all been subject to, ocean acidification, biodiversity loss, and so on. And it has been predicted that climate change is the biggest threat to global health in the 21st century. This is fascinating. Now, as far as climate change in Indian subcontinent is concerned, this is shown here: increases in heat waves, reduced rainfall, glacial melt, and sea level rise. And I will go into this in a little more detail in a few slides' time. Now, the liver disease risk associated with climate change are illustrated here. Although general climate vulnerability tools exist, such as the Climate Vulnerability Index, none of these are liver-specific. And so our evidence comes from mechanistic understanding, physiological impacts of heat-related damage, environmental toxins and pollutants, greater presence of particulate matter leading to actually steatotic liver disease, chronic injury and liver cancer. Infectious agents are increasing, and the migration and overcrowding as a result of the climate change, floods and so forth, also increases disease transmission. And as a result of a lot of this, there's healthcare access disruption in many areas. Now, when you want to think of climate change affecting liver disease, you can see in the green box, we must also consider it in the context of the effects of climate change on digestive diseases, and I wish I had time to give a separate talk about this. But as you can see, high temperatures injure the liver and the intestines as well, and increase intestinal permeability and damage the pancreas, and also exacerbate inflammatory bowel disease and biliary tract disease. Extreme weather, hurricanes and the like cause flooding, physical and mental stress, as do migration and conflict which is resulting. There's damage to the economy, the infrastructure, and the interplay of medical care and the supply chain of food and medications and devices. Air pollution contributes to such entities as eosinophilic esophagitis, appendicitis, irritable bowel syndrome, fatty liver disease, and various digestive disorders. Steatotic liver disease, which has various names, NFLD, MASLD, ALD, etc., these are multifactorial. We're in the presence of what is known as a syndemic, that is a global synergistic epidemic of climate change at the same time as we have obesity and undernutrition. This leads to food insecurity, disruption of agriculture and infrastructure, and unhealthy high energy intake. But there's also malnutrition, and both of these, interestingly enough, cause fatty liver. In other words, metabolic dysfunction associated steatotic liver disease, which was formerly known as non-alcoholic fatty liver disease. High temperatures also discourage exercise and encourage motorized transport use and air conditioning, and all of these result in obesity and greenhouse gas production. There's also what is known as eco-anxiety. Stress, depression, mental illnesses are conducive to excessive alcohol and recreational substance use. In other words, alcohol-related liver disease and chronic viral hepatitis and cirrhosis. Alcohol excess may also be seen in patients with non-alcoholic steatotic liver disease, and this is termed MASLD. And lastly, air pollution with particulate matter actually causes fatty liver disease and even hepatocellular carcinoma. And particles that are smaller, the 2.5 micron particles, are actually more dangerous than the larger 10 micron particles. So here we have air pollution. The particles, after inhalation, are actually transported to the liver through the bloodstream and result in oxidative stress and inflammation. The pollutants cause reactive oxygen species production and inflammation. And at the same time, there's metabolic disruption. Altered lipid metabolism leads to fat accumulation in the liver, and overall this leads to liver disease, cirrhosis, and liver cancer. Now, the global mean surface temperature that the COP21 decided ought to be less than 2 degrees Celsius rise or less than 1.5 has actually increased by greater than 1.1 degrees Celsius and is increasing by 0.15 degrees Celsius every decade. Heat stroke, which is a result of this, is defined by a body core temperature of greater than 40 degrees Celsius. Heat-related decompensation occurs of pre-existing comorbid conditions, including respiratory, cardiovascular, and liver disease. And hypothermia, as I mentioned earlier, increases intestinal permeability, and this leads to endotoxemia. So here you see how each heat stroke causes liver necrosis. On the left-hand side, you see the systemic effects of heat stress, and on the right-hand side, you can see liver injury occurring via direct thermal cytotoxicity, and so forth. So heat stroke can cause liver injury by inhibiting the expression of the hepatocyte heat shock protein HSP70. It promotes the production of reactive oxygen species. It activates caspase and causes pyroptosis, which is a form of inflammatory programmed cell death within the liver. Now, climate change and increased prevalence of liver disease can be caused by infectious organisms. You can see we'll begin with viruses. Here you see the climate changes on the right and the routes of transmission via flooding, via water, and via arthropod transmission. And there you see the routes there. The specific viral infections that we are seeing as a result of climate change are increases in hepatitis A and E, which are waterborne with flooding and so on, hepatitis B and C because of socio-economic hardship and leading to the use of recreational drugs, enteric viruses such as rotavirus, respiratory viruses that go along with the pollution, and vector-borne viruses. And I recently read an article that arthropod vectors are becoming more common in Europe, and these are spreading diseases such as dengue, malaria, yellow fever, and it's expected this will be the same for West Nile virus. More exotic viruses are also increasing worldwide. Now, the second microorganism to consider are the bacteria. And again, these are spread by climate change, mostly via overcrowding and spread by water. The specific bacterial infections that we're seeing increased are Vibrio, especially exacerbations in patients with pre-existing liver disease, and there were notable cases in the coastal Carolinas, which was published in 2020, Salmonella and Campylobacter and leptospirosis. And one unexpected consequence of climate change is that there's actually increased antibiotic resistance in addition to the increase in bacterial prevalence. Now, the third organism to consider are the parasites. And here you see again the routes of transmission the climate changes are the same, the routes of transmission are similar, but this includes being transmitted by snails. And the first of these to consider is schistosomiasis, which interestingly enough is non-endemic in India because the particular snail that transmits schistosoma actually is not endemic in India. Next are the liver flukes, Fasciola hepatica and gigantica, and these liver flukes, you can see the major life cycle is shown on the right. And last, which are rather minor parasites, is the Clonorchus, a minor species, but these are also transmitted by snails. And last we come to the toxin. Climate change favors the proliferation of fungi and algae, which make specific hepatotoxins. The first of these, of course, is Aspergillus flavus and Parasiticus, and these are fungi that contaminate damp grains, nuts, and other foodstuffs in storage, occurring in warm, humid conditions, and these produce aflatoxin, which is a highly carcinogenic metabolite, as you see down there below. In monsoons in Asia and Africa, a white powder appears on stored grains and crops, and this is actually aflatoxin, and this can be prevented by keeping the storage grains dry and below 50 degrees C. Cyanobacteria, colloquially known as blue-green algae, contaminate drinking water and swimming sites and produce microcystins, which are hepatotoxic metabolites that actually cause steatohepatitis. Now let's turn to India rather specifically. The unprecedented heat waves are predicted, with spiking temperatures predicted of 40 to 60 degrees and doubling of heat wave days in major cities, and red alert conditions are already present in northern, central, and eastern India. The monsoons have become erratic, leading to combination of floods and droughts. And the weakened monsoon circulation is responsible for 10% less rainfall. In other words, the droughts that are going to be seen in central India. And the IPCC predicts that 35 million Indians will experience coastal flooding by 2050, and 45 to 50 million Indians by 2200. The Himalayan glaciers are melting, so that water scarcity is increased and will be worse for the population by 2050. Stronger cyclones and sea level rise will cause coastal erosion and mangrove degradation, especially in the Sundrams, which you can see there. There's damage in the coral reefs in the Palk Bay and in the Sundrams, and also in the Andaman and Nicobar Islands in the Andaman Sea, which is east of the Bay of Bengal. It's predicted there's going to be a drop in crop yield in the Indian subcontinent, namely wheat and pulses, of about 9% expected by 2050, and disruption of the infrastructure will affect public health, nutrition, migration, and possibly lead to increased international conflicts over water supply. Now, this is a diagram of the interaction, bidirectional interaction between climate change and the prevalence and care of liver disease, which was a joint effort by members of BSG, BASL, ESL, and ASLD. I don't expect you to go over the interactions, but that way, if you get a copy of this presentation, you can go over them. It's important to remember that healthcare is a contributor to the greenhouse gases, and as healthcare demands increase because of climate change, so the contribution to climate change from the healthcare industry will also increase. So in summary, the negative effect of climate change on liver disease epidemiology in India, you can see down the left-hand column the various mediators of liver injury, mycotoxins, pollutants, hepatitis A and E, and so forth. The climate drivers are shown on the middle column, and these are the ones we've covered: more frequent heat waves, erratic monsoons, hot, humid climate, the growth of aspergillus and algae, disasters, pollution buildup, and so on. And on the right-hand column, you can see the liver impact of these various changes. I won't go through them all, but we've covered them. If we compare what is happening in India to the West, you can see the features that we're considering, such as the drivers of liver disease, infectious diseases, toxins, parasites, etc., on the left-hand column. If you compare India to the Western world, you can see that increased temperature, severe weather events, food insecurity are common to both India and the West. But in India, increased water and food-borne illnesses are due to flooding, poor sanitation, whereas in the West, there's increased transmission of hepatitis B and C because of socio-economic instability, mental illness, and healthcare loss. The risk of mycotoxins, aflatoxin, and contamination of grains and nuts is a particular feature in the underdeveloped world, whereas the risk of the spread of parasitic infections such as liver flukes is more common in the West. Increased risk of malnutrition will occur in India and other less developed countries due to the impact of climate change on agriculture and food insecurity. And similarly, in the West, there's changing food production. The frequent and severe floods and droughts and cyclones affect all aspects of life in India and cause mental stress, whereas frequent severe heat waves in the West cause liver injury and mental stress, leading to alcohol or substance abuse, and so on. And finally, socio-economic disruption causing mental illness and healthcare erosion in India is also the same as in the West. I just want to point out one political statement, and these are 10 key climate initiatives that have been withdrawn or dismantled by the US. The Paris Agreement that I mentioned earlier the US withdrew from this twice, once in the first Trump administration, was reinstated by the Biden administration, and withdrawn again by Trump. And you can see that the US has withdrawn from pledges supporting vulnerable nations, aiding developing countries, a moratorium on wind power, all sorts of aspects that would be favorable to reduce the effects of climate change are no longer supported by the United States. And so this last slide, which I found on the back of a magazine recently, that climate action cannot wait for the politicians. We've seen there's no time to delay, and each of us are responsible in our own way, privately in our use of energy, as institutional use of energy, and also to encourage our nations to be less wasteful about energy use. And I thank you for your attention.
Excellent. It's good to know what climate change generally occurs over many decades. By the time disease comes in, it takes another decade to recognize them. Even when multiple governments globally, they are coming around to work for climate change, I don't see any near solution. It's okay, we all do our little bit. We'll maybe grow trees, or maybe we'll don't pollute our water systems, etc. But still, you still need a global hand-holding to take care of the climate.
That's absolutely true observation, but I have to tell you one disappointing fact. This multi-society task force, of which I'm a member, we produced for the various organizations a strategic plan that we thought GI societies, liver societies should implement to play their part in reducing the effect on climate change. And I can tell you that, disappointingly, none of the societies really made, it was lip service, really made any substantial effort to get their members to participate in activities that would reduce the healthcare burden on causing climate change. And so I think there is lip service being paid in many countries. There's efforts made at zero balance and so on and so forth. But on the other hand, there are some countries that produce so much greenhouse gases, like China, that the effort that we might make in India or in America or in Europe is actually rather less. So something dramatic really has to shake these people into realizing that this is going to destroy our planet.
Thank you.
I just want to, can I just make a small comment?
Please.
I think this was a fantastic eye-opener talk in a medical conference, and I think you highlighted the important thing. There's no disagreement about what you said about climate change. We know it is happening. We are seeing it and of the consequences. But do you think it is, even with policy, really preventable? Because the refrigerators that we use, the air conditioners that we use are all contributing to it. So how do we foresee a life when we are going back to the stage when we're no longer going to use it? And
you know, I have very mixed feelings about this, because this is something that is close to my heart and interest. There is a solution, we can see what it is, but whether governments, individual people, professional associations, individuals are willing to put their money where their mouth is, so to speak. I remember calling one of the senior officials of one of the GI associations, and her reply to me was that she agrees with everything that we have said. She agrees with the things that are in the strategic plan. And yes, her contribution is to turn the water taps off and make sure she turns the lights out when she leaves the room. So it's clear that it hasn't sunk in. And until it sinks in, it may actually be too late. I mean, the heat waves we're seeing, the fires that are raging, the pollution of the of the water and so on is tragic. I haven't suffered from it myself, and I doubt that many people in this room have suffered. And so it's something remote for us. But actually, at the same time, the photograph which I find most poignant of the polar bear mother stranded on an ice floe with her cub because that ice floe broke off of the Arctic ice cap prematurely is really what we're facing. So I understand your skepticism, and I have a mixed feeling of hope because I know it's possible, but also despondency because I can't see enough action being taken. And when a country like the US withdraws from the Paris Agreement twice, and there are 9 other measures that should promote activity against climate change, this most powerful country withdraws, that's when my heart sinks, I'm afraid.
I think global population explosion is a major cause. Global population explosion, particularly in countries like India. Basically, forests are being occupied, riverbeds are being occupied, and ultimately forests are being destroyed. So that is, I think, one of the very major cause of this thing, environmental degradation and environmental.
You're right. The thing that we don't realize, forests are being destroyed for agriculture. There's actually a very famous nutritionist said that the war between the grasses and the trees is being won by the grasses. And what happens? Trees are being lost, carbon dioxide is not being absorbed by the leaves, by the chlorophyll. And at the same time, we have more animals, more agriculture, and so the animals are producing methane and carbon dioxide, which are, again, contributing to the greenhouse gases. I rarely eat meat, I eat chicken from time to time, but I haven't stopped completely. But that's what it's going to take. The idea that animals are dangerous to the environment is something that's very hard to swallow.
I have a counterpoint to that. But the per capita consumption of electricity, meat, whatever it is, in India especially is less per capita. And with a huge population, I foresee an increase in the consumption of meat as well as electricity. How do we contain that?
That is the fear. And the question is whether the governments truly have their money where their mouth is. They're paying lip service, they're doing lots of activity towards this, but is it going to be enough? And I think that modern life, which relies on computers and aeroplanes, use a vast amount of electricity. And we're so accustomed to living like that, and air conditioning and so on, that it's not going to be easy to give it up or to modify it.
And the future is Bitcoin and all those pseudo coins and lot blockchain. They use a lot of electricity, a lot of energy. So that's
right.
worse.
That's right. And people don't. What I've tried to do in this talk is to present to you what the factors are that are in operation. As a hepatologist and gastroenterologist, it's salutary to see how climate change is increasing infectious organisms, viruses, bacteria, parasites, and toxins. And that's just one cause of digestive disease and liver injury. And that's what I've tried to do in this talk, to the few people who are still awake, in this talk to try and bring to you something that I think you ought to be aware of and begin to think how you can play a role.
You didn't have the heads, you had the brains over here.
I think if there are no more questions, we thank you very much.
Thank you.
Thank you. It was an excellent talk. Thank you. And we close this session now.
Thank you, sir. Thank you, ma'am. Now I would invite Dr. Ashish to give concluding remarks.
So we have come to the conclusion of the first day of CHBD 2025. It's been a really enriching day with lots of discussions, thought-provoking lectures, and most importantly, active participation by all of you. We ran behind schedule, but it only shows that how much interest it generated, how much discussion it generated. So tomorrow morning, we will again assemble here at 8:30. I would invite every one of you to have a nice dinner and have good restful sleep, and then come back here at 8:30 in the morning so we begin tomorrow's session. Thank you, and have a great night. Thank you.